All right. Good morning, everybody. I wouldn't exactly call it a bright morning, but it's a typical winter Pittsburgh morning. Get used to it. All right, everybody. I have now transitioned from the skeletal system. We're now going to be going to the cardiovascular system. All right. Now, at the end of this class, I could probably ask you to tell me, do you have a favorite system? All right. Now, some of you will have preferred systems. Most of you hate the endocrine system because it's too much to think about, all those control systems and how they interact. A lot of you like the nervous system, but probably generally most people like the cardiovascular system. Don't know why, but nonetheless, okay, you can have your favorites. That's fine. It's not like we can really tease them all apart anyway. All right. So the focus for the next few lectures will be the cardiovascular system. Right now, you already know what it's critical for because I've already discussed that. It is basically, as the name implies, responsible for primary delivery of stuff throughout the body. All tissues, with the exclusion of cartilage, are within 50 microns of a vascular supply. It's critical for moving gases, both CO2 and O2. It's critical for moving nutrients and communication signals, etc., as well as removing wastes. Okay, so it serves primary purpose. Right now, when we talk about the circulatory system, as you're going to see, it's a couple of closed loops. Right, so the whole purpose is to perfuse blood throughout the body. That means that you have to have something to force that blood through that circuit. Right, you need a pump. And the primary pump that I want to start with is the heart. Notice the word primary. The heart is not the only pump in your body. There are secondary pumps too. They're not hearts. They're not like little hearts or something like that, but we'll get to that later. But obviously, without the heart as our primary circulatory driving device, we would die. All right. So that's when you have a cardiac infarction. That's when your heart fails. You can die. Right. So what I want to start with this series, let's start here at the heart. So what I want to do over the next few slides is, number one, discuss the anatomy and how it's unique for humans. And then we'll discuss how it works. And we'll talk about control of the heart and so on. All right. So let's begin with a general anatomy lesson. All right. In humans, we have a four-chambered heart. We have two atria and two ventricles. The atrias are on top, the ventricles are on the bottom. Right? Now, the reason we have four chambers is because we have two circuits. We have two circulatory circuits. We have something called the pulmonary circuit. That's the blood that leaves the left ventricle, enters the pulmonary circuit. That obviously delivers blood to the lungs. This is for oxygenation purposes as well as then blowing off CO2. The blood is returned back to the heart. And then once it leaves in the left ventricle, it will enter the circulatory, the general systemic circuit, which goes everywhere else. Okay. Then it's returned and then the blood is done. So for every heartbeat, that's when this contracts and relaxes, and we'll talk about what that consists of in a moment. You are simultaneously pumping blood into both of these circuits, right? This is highly efficient, but is it necessary for having a heart to function? No, it isn't, all right? If we talk about a reptilian heart, a lizard, a frog, or something, they only have two chambers. They have one atria and one ventricle. They get along just fine. Okay, so but for us, we have four chambers, right? Actually, if we go early enough in utero as a fetus, you actually have this. You have a heart which is like a little tube structure, and it squeezes and contracts, squeezes and contracts. This is before you get the full development of this heart. You it takes time for this to develop. All right. Now, so we have the right atrium, the right ventricle, the left atrium, and the left ventricle. Right. So let's start up here at the right atrium. This is the blood that is returned via the systemic circuit. It enters the right atrium, right? From here, it will go through this valve, which I'll talk about in a moment, and enters the right ventricle. When this contracts, the blood leaves the right ventricle, it enters the pulmonary circuit. It returns via the left atrium. From there, it goes to the left ventricle. From there, it goes back to the systemic circuit, and we continue this circuit. All right. Now, so let me get a few things. Up here in the right atrium, this again is the blood returning from the systemic circuit. What is unique about this atrium is there are two pacemakers that are here. What's a pacemaker? This is a set of nervous tissue, neurons, which will set heartbeats. They regulate heartbeat. And you have two of them. The first one up here is the sinoatrial valve. That's at the very apex of the right atrium. We'll talk about what it does in a moment. Other than that, it's a pacemaker. Then there is another pacemaker down below at the lower aspect here, just before the blood leaves the right atrium, and that's called the atrioventricular valve. So we have the SA node and the AV node. All right, they are they're basically two pacemakers. The primary pacemaker is the SA node. Okay, it fires first. Then secondarily, there's a firing of the AV node. All right, now what I want you to look at is here. This is called a septum. This is dividing the ventricles into your left and right. And this tissue here, what we have is the AV node actually has electrical tissue running down this septum that separates the two ventricles. Note that it comes down to the apex of the heart and back around. These are called the bundles of His. Okay. And basically what happened, and then they end in these Purkinje fibers. Note that these Purkinje fibers are associated with the valves as well. So we'll talk about how contraction works in a minute. This is just basically the anatomy. All right. We'll describe the valves in a few minutes. All right. So basically, we have four chambers, two atria, two ventricles. Blood enters from the systemic circuit to the right atrium. It goes from there to the right ventricle. From there, it goes into the pulmonary circuit. It enters the pulmonary artery. Right. From there, it is returned to the right atrium, the left atrium via the pulmonary vein. Now, it then goes into the left ventricle, and from there, it goes via the aorta. It enters into the systemic circuit, and it is returned via the vena cavas. Okay, to the right atrium. We start the whole process over again. All right. Now, here's a good place for me to say this. What's the difference between an artery and a vein? Anybody? Yes. No, it's the same. What do you mean by flipped? You just answered your question, right? So this is critical. Most people think, because they're thinking in terms of the systemic circuit, they think that an artery is going to be more oxygenated. That's true for the systemic circuit, but it is not true for the pulmonary circuit. All right? When the blood enters the pulmonary artery from the right ventricle, it's furthest away from the lungs. Okay? Because it's the tail end of the systemic circuit. So it is the least oxygenated blood. And it is an artery because the blood is coming from the heart, right? Once it passes through the lung and is returning, now we have the pulmonary vein. This is the most oxygenated blood because it's closest to the lung. It just left the lungs, all right? Okay, so The systemic circuit, on the other hand, it's closest, the aorta is closest to the pulmonary aspect, pulmonary circulation, so it's closest to the lungs. It's the most oxygenated. By the time it passes through all the tissues in the body, gives up the oxygen, it's the least oxygenated when it returns via the right atrium. Okay? Now, when do we go from an artery to a vein? That is the capillaries in the middle. That's the transition point, right? So you have capillaries in your lungs, and then once you pass through those capillaries, now you transition to a vein. And we'll get to that later. This is a good place for you to note, because a lot of you just mistakenly think that arteries are more oxygenated. It all depends which circuit we're talking about, all right? Because that's not the way you should define it. You should define it as blood is flowing away from the heart or blood is returning to the heart. Transition point will be the capillaries, okay? Okay, now, heartbeats are driven by, obviously, neural stimulation, all right? This is where the pacemakers come in. This is where the AV and the SA and the AV node come into play. The SA node is the first pacemaker. It fires first. This is responsible for initiating the contraction of the atria, and their purpose is to force blood into their respective ventricles. The right atrium into the right ventricle, the left atrium into the left ventricle, all right? Then we will have the firing of the AV node, and that is responsible for initiating contraction of the ventricles. The ventricles then contract, and that forces blood into the respective pulmonary circuit or systemic circuit. All right? Now, so what you're looking here is an electrocardiogram. Right? This is very easy. You put these electrodes on your chest, and you can actually measure the electrical activity of the heart. This has tremendous capacity to tell us a lot about the heart. All right? I just saw there was a paper just published, I guess it was yesterday. They're developing AI being applied. They're getting thousands and thousands of these things where they can actually give you a prediction about your what's called the cardiac health. Okay, that has nothing to do with your age, but that's how good your heart is. Now, the problem is that this is just beginning. There's a variety of models, and the model system is only good if you do trash in, you get trash out. So I don't even think we're going to have a functional set of models for about 10 years or so. All right, it's going to be a while, but it's beginning. All right, so. But let's get really, really simple. What is an electrocardiogram? What are you looking at? You are looking at the electrical conductivity that's responsible for a heartbeat, right? A heartbeat consists of the contraction of both the atria, their relaxation, the contraction of both ventricles and their relaxation. Remember, atria essentially contract at the same time, ventricles essentially contract at the same time. So you simultaneously are moving blood from their respective atria to their respective ventricles. The ventricles contracting, moving blood simultaneously to either the pulmonary circuit or the systemic circuit. All right, so here's a heartbeat. Your SA node fires. This is initiating contraction of the atrium. Now, yes, it begins in the right atrium, but it rapidly transmits over to the left atrium as well. So both atria are contracting down. They're forcing blood into their respective ventricles, right? That is this first little wavelet here, right here, called the P wave. Now, what happens next that you see in electrocardiogram is this huge wavelet, which is the QRS complex. This represents the contraction of the largest set of chambers in the heart, the ventricles. They're much, much larger than the atrium. So when they are, it takes a lot more electrical stimulation to initiate their contraction. This is a result of the firing of the AV node, right? So basically, we get this huge wavelet, this QRS complex. This is contraction of the ventricles. We next have a slight delay. We next see this next little wavelet called the T wave, which represents repolarization or relaxation of the ventricles. All right. So this is a simple heartbeat. You have a P wave, a QRS complex, and a T wave. Every heartbeat, normal heartbeat. What do you not see in this electrocardiogram? Based on what I've just been talking about, what do you not see? Anybody? Exactly. And you know why? Because it's occurring at the same time we're having contraction of the ventricles. And since the ventricle stimulation far exceeds that of the atrium, it's hidden here. It's here, you just can't see it. Okay? But you're correct. Technically, you don't see it in the electrocardiogram, but it's buried here. Right? Because you have, yes. What you do not see there, okay, so you have contraction of the atrium, you have contraction of the ventricles, you have relaxation of the ventricles. What you do not see is relaxation of the atrium because that's occurring here. This signal overrides that signal. You just can't see it. It's here, you just can't see it. All right?
How do we know it's there?
Good question. I mean, well, I guess if I disconnect, okay, so I know what could be there. For instance, if I disrupt the communication between those two, the SA and the AV node, so the AV contract, the ventricles don't, then I could see it. It's not going to be good for you, but I can see it. Okay. All right. So at every heartbeat, you get this set of wavelets, a P, a QRS, and a T. A P, a QRS, and a T. That happens. Let's see. I just had my annual checkup a couple of weeks ago. My heart rate is around 65 beats per minute, which isn't bad for an old fart. Yours should be around 65, 70 beats per minute. Okay. That happens all the time. Remember when I was introducing the muscular system, I said the cardiac muscle is capable of continued work with limited times of elevated levels of work, right? So your heartbeat is like, say, 70 beats per minute. If I ask all of you to stand up and run in place, in about a minute, your heart rate would start elevating in order to deliver blood to those working skeletal muscles. And it would go up. So depending on the level of activity, it could go up to 150, 200 beats per minute or something like that, but not much over that under normal circumstances. Then when you stop exercising, it would slow back down again. The one thing it will not do is stop, because once it stops, no blood is being moved. And especially in regard to your brain, if you're deprived the brain of oxygen for more than about 15 seconds or so, you're going to pass out. Much more longer than that, you won't be around with us much longer. Okay? All right. So this is an individual heartbeat. Obviously, I'm spending a considerable amount of time on this, so I expect you to know it. All right? So you need to know what this is. What these wavelets represent? Now let's talk about the contraction waves and what they're resulting in. All right, so we start up here at the SA node. It initiates a wave of contraction, which is this yellow color that you see. All right, note that it begins in the right atrium. It rapidly translates over to the left atrium. So they're both contracting. They're both forcing blood through these respective valves into their respective ventricles chambers. Right. Note that also note that the anatomical location of these pacemakers, the SA node is up here just as the blood enters in from the vena cava, and that the AV node is down here at the bottom of the right atrium. All right, so that means that we have full initiation of contraction of both atria before we initiate firing of the AV node. Also note that the purpose of contraction of the atriums, it begins up here at the anterior aspect, and then it's forcing blood down to the respective ventricles, right? Now, when the ventricles contract, the blood exits them up here. So we want to, the most efficient form of contraction is to initiate contraction from the apex of the heart, forcing the blood up and out. So that's why you have the anatomical location of the AV node here at the lower aspect of the right atrium. Then via the bundle of His, we now, when this is initiated, firing is delayed because we want to fill these ventricles. When it does initiate contraction, it initiates down here at the apex. So now when it starts to engage, it forces the blood up and out, either in the pulmonary circuit or the systemic circuit. Okay? So that's critical. That's why we have the anatomical location of the atrium, the ventricles, the two different pacemakers, and how the AV node is delayed. Okay? So you're with me so far, right? And if you look down below, you can see that how that corresponds to electrocardiogram. All right, let's talk about those valves. Right? The valves are responsible. I know there are no plumbers in this group. I know better than to ask that. So there's something in plumbing what we call a check valve. A check valve is a valve that ensures unidirectional flow in a system. Okay? That means it will allow flow only in one direction. All right? Your heart has 4 valves. They serve exactly the same purpose as a unidirectional flow valve, right? A check valve. So when we have, and they exist between each atrium and then the ventricles to the respective circuit. Okay? So as blood enters the right atrium, and then it goes to the right atrium to the right ventricle, it passes through the tricuspid valve, right? Now, at the same time, the blood is passing through the tricuspid valve to the right ventricle. It's also passing through the mitral valve into the left ventricle. Now, remember, the blood that enters the right atrium is coming from the systemic circuit. The blood entering the left ventricle is coming from the pulmonary circuit, right? Now, as the atrium contract, they're going to force blood through here. So the valves are open for flow only from the atria to the ventricle. Now, the atriums stop contracting, right? So what that means is the blood normally would want to flow back into the atrium, but it can't because these valves close. Notice the anatomical location here. So they're set up to allow blood flow in this direction, but when this flow starts and we start putting pressure here, it will close this off. That means that there's only one way the blood can go. It cannot, under normal circumstances, it can't go back into the respective atria. It has to leave the ventricles. In the case of the right ventricle, it passes right through here. This is the pulmonary valve entering the pulmonary circuit via the pulmonary artery. Okay? Again, note that this is a unidirectional valve. The blood, that means the blood, when this ventricle contracts, this closes, this opens, blood then enters the pulmonary circuit. Over here in the left ventricle, it's filling via the mitral valve. When it contracts, that means that the mitral valve closes, and then the aortic valve opens and blood leaves the left ventricle entering the systemic circuit via the aorta, right? So we have 4 valves. There are 4 check valves. There's 2 valves between the atrium and the respective ventricles, and there's 2 valves, one at where the ventricle goes into its respective circuit, whether it's the pulmonary circuit or the systemic circuit, right? So in every heartbeat, we have essentially, so when the heart is relaxed, okay, So this is initiation of a heartbeat. What happens is there is passive filling of the respective atrium due to either the systemic blood pressure or the pulmonary circuit pressure. Okay, that fills both atria. We now then fire and initiate contraction of the respective atrium. They will simultaneously force blood into their respective ventricles. Right? Then those atrium them. Okay. All right. Let me double check to make sure the recording is still happening since I did that. Yep. Okay. So every heartbeat, we have blood being forced down to the respective ventricles during the contraction of the atrium. Now we have relaxation of that, and now we have contraction of the ventricles forcing blood up and out either into the pulmonary or the systemic circuit. And then it relaxes, and what happens? When it relaxes, when these ventricles relax, these check valves close. So these check valves close so we don't have blood coming back, regurgitating back into the ventricles. We don't want that under normal circumstances. That means the only way the blood can refill this is from the atrium. Right? Everybody with me so far? I know I'm spending a lot of time here, but if you don't understand how the heart works, we might as well give up. Right? So, a colleague of mine about 20 years ago taught me this, and it is, how does a heart beat? How does a heart work? What is the simplest way I can project that? And she proposed this, and I've used it ever since. You can't get any easier than this. So what you're looking at is the heart and the blood flow through the circuits. All right. So the heart is easy. It's got 4 chambers. So it's represented by a square with 4 equally spaced squares inside. Okay. So draw a square, draw a cross. You've got 4 chambers. We start up here by convention in the right atrium. This is where the blood is entering from the systemic circuit via the vena cava. Okay. The arrow then goes to the right ventricle. From the right ventricle, it leaves to the pulmonary circuit via the pulmonary artery, goes to the lungs, returns via the left atrium and the pulmonary vein. And then from there, it goes to the left ventricle. From there, it goes to the aorta and the systemic circuit. And then we have this thing going back here. All right. Now, throw in your valves, throw in your tricuspid, etc. All right. Chances are, whether it'll be a quiz or an exam question, this is just a good way of thinking about the anatomy and then how blood flows through the heart. All right. So everything I've talked about is replicated here with you can put in your valves. All right. So I expect you to understand this part. Okay. All right. So electrocardiograms have been around for approximately 100 years. 100 years. And we still use them today. Now, when I remember the transition from paper to digital, all right? That happened around in the 70s, early 80s, all right? Before that time, everything was paper, right? There's advantages to paper. You have a permanent record. You have a digital record, you just have to replay it, okay? Or you have to print it, whatever. But I'm showing you paper, but it doesn't matter. Today, it's all digital. Yeah. Have you ever watched the doctor shows? You have your patient in the hospital and you see this little monitor and you see you'll see this, all right? Then it flatlines, which means it ain't working and they're going to die if you don't intervene, right? So if we look up at top, this is a normal heartbeat. It's referred to as a normal sinus rhythm. That's all that simply means. Normal sinus rhythm just means a normal heartbeat. Okay. Now, I'm specifically showing you this so that you will see that before, when I was first talking about a heartbeat, I said we have a P wave, a QRS, a QRS, and then T. Right? I over exaggerate the QRS complex. But in a real normal sinus rhythm, it may not look like this. You may not notice here that you really don't have that Q coming way down and then the RS. All right. But they're still normal because you have a P wave, a QRS, and a T wave. That's every heartbeat. There's a delay and so on. So if you look up here, you can see, and you can actually determine the number of heartbeats, but what you're also determining from these electrocardiogram is I have normal functionality. Now, how can electrocardiograms be used to diagnose pathological conditions? I'm going to show you several examples. Right? So the bottom one here is referred to as a junctional rhythm. So first off, let's look at the electrocardiogram. What you don't see here is a P wave. You see a QRST, QRST, QRST. What does this mean? That means that the ventricles are functioning, the atrium are not. Because remember, what is a P wave? P wave is contraction of the atrium, right? Now, first off, so what does that mean? That means that the primary pacemaker, the SA node, is not working. But you got two. Okay, remember the SA node is directing contraction of the atrium. The AV node is contraction of the ventricles. What you also need to realize is the purpose of the atrium is to fill the ventricles. Okay. However, and that also means if your atrium aren't working, you're not dead because you got the backup. Right? But, so that means your ventricles are still contracting. Now, what does that mean? That the whole purpose of the atrial contraction is to fill the ventricles. If they're not working, you're just dependent upon the pressure in the existing circuits, feeling those passively. It's not efficient. You're not going to win any running races or anything like that, but you're alive. All right? Let's move on. Up here, what you're seeing is a second-degree heart block. All right? So if we go here, we see a P wave, another P wave, then a QRS complex, and a T wave. A P wave, a P wave, a QRS. In other words, what we're seeing is that we have basically the opposite effect. In the first one, we weren't getting contractions of the atrium. Here, we're getting essentially a double contraction for every ventricular contraction. That means that the signals are not passing from the SA node to the AV node. Okay? That there's something blocking that. All right? So we get two atrial contractions for every ventricle contraction. What does that mean? We're overfilling the ventricles. So in the long haul, we're overworking those ventricles, all right? But we're still alive. Let's drop down here. This is ventricular fibrillation. What does this mean? You basically got a heart attack. What does this mean? There is no periodicity to this. There's no rhythm to this. That means that there is no organized contraction relaxation. That means that blood is not being pumped through the respective circuits. That means you better intervene or you're going to die shortly. That's why we have those AED devices, those little red boxes all around campus. You've seen them. Have you ever been trained to use them? Probably not. Okay? But they're there. So let's think of this system here as your computer system. What happens when your computer just freezes up? What do? You reboot it. All right? That's the purpose of those AEDs. What they do is they're going to provide an electrical stimulation that override. So the point here is this is in need of a reboot. An AED is going to give a burst of electrical energy that will then try to initiate or reinitiate a normal heartbeat. So that means it re-engages the AV and SA nodes, right? So you may have to do it a couple of times. And basically what it does, it just restarts the system. And then those pacemakers take over and you get normal. Now, this is ventricular fibrillation, which means blood is not entering the respective systemic or pulmonary circuit. You also have atrial fibrillation. That's a little different because you still have normal functionality of the ventricles, but your atrium are not really working that well. Okay, so atrial fibrillation, you're not going to die right away. All right, you can still be alive because that's kind of but you have to have the ventricles working in order for this to happen. All right, so these are just several examples of how electrocardiograms can be used to diagnose normal versus pathological conditions. Okay. So I spent some time. This is your heart. These are the chambers of the heart. These are the valves of the heart. This is the direction of blood flow through the cardiac, through the heart, as well as the system, through the various circuits. And we've talked about electrical control. The purpose of the heart, obviously, is to pump blood. So when we talk about the work that is performed by the heart, we're talking about pumping blood. Okay? So let's talk about that. We call that cardiac output. That is the amount of blood that leaves the heart during a heartbeat. That is basically, and that means the blood leaving the left and the right ventricles together because they're simultaneously pumping or contracting. Okay? So basically, what is that? So cardiac output is basically heart rate times stroke volume. Heart rate is obvious. That's the number of times the heart beats in a minute. That's the number of ventricular, if you want to think about ventricular contractions per minute. Next is how much blood leaves the heart during those ventricular contractions. That is your stroke volume, right? So heart rate times stroke volume gives you the total cardiac output, okay? Now, so let's say that you have 70 beats per minute, then your stroke volume is 70 mils per beat, so that'd be 70 by 70. That works out to be about 5 liters. Oh, that just happens to be the total volume of blood in your body. So every minute, you are pumping the equivalent volume of all the blood in both circuits through the heart, right? Now, let's talk about what is the SV? What is your stroke volume? All right. So basically, it represents the difference between the volume during the total filling of the ventricles, that's during the relaxation, and the remaining volume during contraction. All right. So we talk about the end diastolic volume and the end systolic volume. The end diastolic volume means during relaxation, the ventricles have filled, right? Then the ventricles contract, and then not all of the blood is expelled into the respective circuits. Some remains in the ventricle. This is referred to as the end diastolic volume. Okay, so you have the EDV and the ESV. If you subtract those, you will then get that. So your EDV, this is under normal fill, your ventricles will have 120 mils contained. When they undergo contraction, they will then expel approximately 70 mils, leaving 50 mils in the ventricles. All right? The difference is 70 mils per minute. Okay? All right, so we have 120 minus 50 is 70 mils. All right, now, so the whole purpose here, this is how we measure work of the heart, is how much blood is being pushed through unit of time. Now, What affects stroke volume? All right. So notice that your during ventricular contraction, there's still 50 mils. So this means that we are not maximally forcing all the blood out of the ventricles during their contraction. Right? So let's talk about what's going to impact stroke volume. Stroke volume is two things. Remember, stroke volume is two things. Stroke volume is the fill volume during relaxation of the ventricles and the remaining volume after contraction. There's a couple of ways of thinking about it. Number one is preload. That's the volume in the ventricles during relaxation before we initiate contraction. So think back to what we were just talking about. All right. Go back here. What about not junctional rhythm. Let's think about second degree heart block. What's happening here? We're having 2 atrial contractions for every ventricle contraction. That means that we are double filling those ventricles. So we're increasing the preload on those. Okay? So that means that that's going to have an obvious implication for your cardiac output because it's going to increase stroke volume. All right? Because what we're doing, instead of 120, maybe it's 150. So 150 minus 50 is more than 70. All right? So I just want you to start thinking about it like that. All right? Next is contractility. So contractility is how hard those ventricles are contracting. They're obviously not maximally contracting because there's still 50 mils left during post-contraction. What happens if I increase the intensity of contraction? That's like squeezing that sponge harder. I'm going to get more blood out. Right? How am I going to do that? Stimulate the nervous system. I can stimulate, basically, I can use catecholamines, and that's going to induce contractility. That means I'll squeeze harder. I force more blood out. So I'm not impacting the 120, the EDV, but I'm decreasing the ESV because I'm increasing contractility, forcing more blood out. So maybe there's only 10 mils left in there. So again, it's the difference equals the stroke volume. So I can impact stroke volume by preloading, increasing contractility, or lastly, afterload. What's afterload? All right. So the blood leaving the ventricles entering the respective circuit, it's not like a garden hose where the water just goes out into the air. It's a closed circuit. So there is a pre-existing pressure in each of those circuits. Let's talk about the systemic circuit. In order for blood, so the left ventricle contracts. It's going to force, the intent is to force blood into the systemic circuit, entering the aorta. In order for blood to leave the left ventricle and enter the aorta, the pressure in the ventricle has to exceed the pressure in the systemic circuit. That's what is called the afterload. Now, so that gets us to blood pressure, and we'll talk about blood pressure in a moment, but what's the disadvantage of having high blood pressure? So think in terms of afterload. That means the heart has to work harder, the ventricles have to contract more in order to overcome the load resistance of the afterload. So they have to work harder in order to pump blood through the system. That's number one. Number two is if you have a rubber tube and you overfill it and you really increase the pressure, at some point you will exceed the capacity of that vessel to hold it, and it ruptures. And that's called an aneurysm. Okay, that happens too. I'm involved in an AHA project where we're looking at abdominal aneurysms, say aortic aneurysms. That's where the aorta gets really thin, it expands, and then of course if it does rupture, you're dead. It happens in humans. And if it does rupture, I don't care whether you're on the surgical table or not, you're going to die because you'd lose your blood too fast. All right. So the only way, what you want to do, if you get someone with a developing aneurysm, you want to reduce that impact. Okay, because once it does rupture, that's it. Right. So the three most important factors affecting stroke volume: preload, contractility, and afterload. Right. Now, up to this point, other than talking about junctional rhythms and so forth like that, we've talked about everything's functioning properly. But let's talk about, I spend some time talking about cardiac myopathies. And these are pathologies associated with the heart. All right. Now, we talk about myocardial ischemia. What's ischemia? That means you're depriving tissues of oxygen, which means you're depriving tissues of blood because blood is delivering the oxygen. So if I have a disruption of the circulatory system, anything downstream will be potentially deprived of oxygen, right? This also happens in the heart, right? Now, let me see here. I guess I did not. Okay, so wait a minute. I've got 5.5 liters of blood going through the heart every minute. Why is there an issue? That's blood in the chambers of the heart. All right. That's not the actual cardiomyocytes. Those heart muscle cells do not exist in that open space. They're in the surrounding space of the atrium and the ventricles. They're the ones that are responsible for contraction. They have their own circulatory system. Okay, so the blood that goes to the chambers has no impact on the heart tissue itself. It has its own vasculature, which are called the coronary circulatory system. All right, that delivers blood to those cardiomyocytes, those heart muscle cells. If there is a disruption of delivery of blood to those cardiomyocytes, they need oxygen to work. And if you deprive oxygen, they don't work. All right. And that is referred to as myocardial ischemia. All right. Now, an acute myocardial infarction or a heart attack is when we have a disruption of blood delivery to those cardiomyocytes. This means through the coronary circulatory system. And you can have a variety of outcomes. The worst outcome is you die. And we'll talk about that in a bit. So basically, this is when we're disrupting blood delivery to the heart. We'll come back and visit that in a moment. The next thing I want to talk to you about or introduce to you in this slide are murmurs. Murmurs are basically heart sounds that are abnormal. Everyone has had a stethoscope put on their chest at some time or another. Okay? So, what is a stethoscope and what is its purpose? All right? A stethoscope allows a physician or a medical person in order to do two things. There's two things they use them for. Number one, you can actually listen to how air flows through your respiratory system, but let's take that out of the system. We don't care about that right now. We care about heartbeat. So I can actually hear your heartbeat, right? Now, originally, how would you do that? You'd put your ear up to the chest of the patient and listen to it, all right? We don't need to do that. Next, you can take a piece of newspaper and make it into a cone, and that works too. But then a traditional stethoscope is just another way of doing it. And basically what that does, that augments the beats and allow you to hear it. And so what you're listening for is a heartbeat. And what a normal heartbeat sounds like is lub-dub. It sounds like lub-dub, lub-dub, lub-dub. Each lub-dub is a heartbeat. Okay? You have 70 beats per minute. You have 70 of those lub-dubs per minute. All right. So a physician is going to be listening to that. What are they listening to? They're listening to the blood flowing through the valves. Okay. You're not going to hear blood moving through your vasculature here. What you're listening to when you hear that lub dub, the first lub is the blood flowing from the atrium through the respective, either the tricuspid or the mitral valve into the respective ventricles. The dub, the lub, that's the lub. The dub is the contraction of the ventricles, and then the blood is flowing either through the pulmonary or the aortic valves into their respective circuits. So every time you hear a lub dub, that's the contraction and the blood flow from the atria to the ventricles and the ventricles into their circuits, right? So what you can do if you're listening to that, you can also listen for abnormal sounds which reflect a dysfunctionality of those valves, right? So I'm going to give you a couple of examples. The first one is a stenoic or a stiff valve. And most of the time, it's irrelevant when you're all grown, but when you're children, developing children, what can happen is everyone's heart isn't developing at the same rate, and the valves can be problematic. And sometimes you're listening for problematic valves. Do I need to intervene? Do I not? So the first thing is, if you have a stenoic valve, that means it's stiff. That means the valve doesn't open adequately. It opens too slow. That means, what does that do? That's going to, if it's not opening fast enough, that's going to disrupt blood flowing from the atria to the ventricles, or the other way, or from the ventricles to the particular circuit. Now, and so basically what that means is it's going to create more turbulence. The sound's going to vary. All right. Now, this is a stiff valve. We can also have an insufficient valve. That means that the check valve isn't doing its job. That means it's allowing some blood to go back. So it goes from let's say it goes to the mitral valve into the right ventricle, but when that atrium relaxes, it's an insufficient valve, so some of the blood goes back into the atrium. So it's regurgitated back, okay? Number one, this is inefficient, but number one, this creates some turbulent flow and it creates different sounds, all right? And if you're trained, you can actually measure, you can actually do that, all right? Now, so those are things normally under most circumstances, we associate them with childhood development issues, but usually patients outgrow. One thing patients do not outgrow is a concept called rheumatic fever. All right. Rheumatic fever is basically, it was actually rather common until here in the States till approximately the 1940s or so, when antibiotics became general usage. Prior to that, it was actually common. What is it? It is a bacterial infection that sets up in the heart valves. It's a chronic establishment. It disrupts, it damages the valves, and they lose their functional control. And this is referred to as rheumatic fever. My maternal aunt had that because she definitely predates the 1940s. She had it as a child because it's always associated with children. And there is no solution for it at the time. So, well, actually, the only thing was that usually you then transition to warmer climates, so it's less work for the heart. Now, the heart is weakened permanently. It's irreversible. In her case, I mean, generally, it all depends on how much damage has been done. In her case, she lived to her late 70s, which is a surprisingly long time, but not terribly uncommon. All right. Now, today we don't, in the United States, I don't think there really is any cases of rheumatic fever. However, there's still rheumatic fever. Most of the rheumatic fever, I remember there is a big uptick in sub-Saharan Africa for obvious reasons. You have war disrupting. There's no source of antibiotics to treat bacterial infections in children. And so there's a big uptick in rheumatic fever observed there. All right. All right. Now, let's go back and revisit. I was talking about how ischemia myocardial ischemia is a result of the blocking of blood moving through the coronary arteries. All right. And those are the blood vessels that are feeding the actual cardiomyocytes. Right. Now, what it means is if we so we have blood flowing through this, if we stop it someplace, everything downstream is being deprived of blood. Being deprived of blood, being deprived of oxygen. Right. Now, there are three mechanisms that are going to disrupt blood flow through that coronary artery system of the heart. The first, and I'll cover all three of them. The first one is a vascular spasm. Okay, what's a vascular spasm? A vascular spasm is, do you know the Polar Bear Club? Anybody know what that is? Ice water.
Yeah.
Yep. After the new year, idiots will strip down to the bare minimum and they jump in cold water for some time frame. That's called the Polar Bear Club. Okay. One thing that happens during that time point is there can be a spasm where your heart stops beating for a couple of moments. Okay. It's just a shock to the system. It stops beating. It's reversible. You don't die, but that's what's reflected by this vascular spasm. Okay. Now, let's move to the next two. The next one is atherosclerosis. Okay, so let's spend a little bit of time talking about that. So atherosclerosis is basically, it's a chronic disease. It's where your vasculature has a functional pathology. So basically what happens is we have a normal blood vessel, and a blood vessel, the lining of all blood vessels as well as chambers of the heart are cells called endothelial cells. Think of endothelial cells as Teflon coating on your fry pan, all right? So they allow blood to flow through uninterrupted. Surrounding this, there is some fibrotic, some connective tissue. There are also some smooth muscle cells and so on. Right now, in atherosclerosis, what happens is you get depositions of cholesterol underneath those endothelial cells. So, in other words, cholesterol is leaving the blood. It gets in the actual wall of the blood vessel. All right. This forms what is called a fatty streak. The deposition of this fatty streak between the endothelial layer and the outer aspect of the vessel promotes the invasion of additional cells, which are basically they're smooth muscle cells. They're invading, being attracted to this lipid fatty streak, and they make what are called atheromas. So they over-multiply, and what this does, this results in a plaque formation. I'll draw you a picture in just a moment. And what happens is as that plaque grows, it means that that vessel is no longer a nice smooth tube. Right? Now let me show you what I mean. I'll do a cross section here. Let's see. Okay. Okay, here's a normal blood vessel, cross section of a normal blood vessel, right? So we now have a fatty streak coming in here like that, right? So that's cholesterol going in here like this, right? Now, with this fatty streak, most of the smooth muscle cells are here. They will invade. And what that results in is the formation of the plaque. That's the combination of the fatty streak and the atheroma. Okay, you have your plaque. Now, at this point, it has no effect on blood flow through this section of this tube. But what happens is this continues to grow. This continues to grow. What does that mean? As that continues to develop, the cross-sectional area, this goes down, So we're starting to occlude this vessel. If that plaque gets big enough, it could essentially occlude that vessel. All right. So this is atherosclerosis. It takes a long time to happen. And when it is associated with the coronary arteries of the heart, if it goes to the point where it can deprive them, you're going to offer ischemia. All right. Now, how do you address it? So you have a patient, he comes by, and there are a number of clinical tests, I won't go into those, and you have a developing atherosclerosis, right? How do you treat it? There's two ways to treat it. The classic way to treat it is bypass surgery. So what's bypass surgery? So that's basically taking blood vessels from one part of your body, your leg, saphenous veins, and you put them up here in the cardiac circuit. You bypass this so the blood continues to deliver. So you can have a bypass surgery, a dual, triple, quadruple bypass, right? What's involved? It's open heart surgery. They crack your chest, they expose and they have to get to your heart in order to put those bypass vessels in place. Very painful, very long time recoveries, but you're alive. I've had a number of colleagues who've had bypass surgery. All right. Next, what else can you do? There is a less invasive way that you can work with it as well. Let's go back here and use this. So here's a blood vessel. We have an occlusion here. I want to remove that occlusion without doing bypass surgery. What can I do? I can deploy a vascular stent. What's a vascular stent? So basically, we have a device which will have, think about this being a device I can take and put it up, say here, I go through my femoral vein, I come back and I can feed it into the coronary aspect where I want it to be. This is it. There's a balloon device here. And then there is this collapsible, either metal, usually they're metal cage type device. It's in a circular path. Now it's this big. We get it where it needs to be. Then we put air into that bladder that swells it, that stretches this metal cage. And the metal cage then expands and does not go back. And that opens up this channel. How does it work? Like this. So here is a cross-section area of this. As it expands, the air bladder is going to leave this metal cage. Think of, you've seen different kinds of woven devices. There's the finger trap things you put them in your finger, you pull them tight and they pull tight and they go back and you don't know what I'm talking about. All right, so basically, think about this as just a woven piece of metal, because that's basically what it is. And it expands out, but once it expands out, it doesn't go back. All right. So I use air to expand it. So what I do is it goes up. This here is pressed here. So it opens up. Okay. Minimally invasive, no cracking of chest, no major surgery. There's a couple of downsides, because depending on how you do this, sometimes pieces of this can break free. And so basically what they do is they have these little nets that are downstream to catch that kind of stuff. Okay, but these deployment of stents as well as bypass surgery are the two ways that you can overcome atheroscleroma or try to keep from happening it in the first place. All right, since it can be associated with cholesterol, there's all this argument you need to regulate your cholesterol levels, right? Now, I'll get into more details later, but did you know that of the cholesterol level in you right now, only 20% is due to dietary consumption? 80% of your circulatory cholesterol, your body's making it. Okay? So most of you here are normal, healthy young adults. That means it doesn't matter how much cholesterol you eat because it's not having a major contribution to your circulating levels. Where it's important is if genetically your body is making a shitload of it. Okay? So if you're making a lot of it, that means that dietary consumption plays a major impact because it can really knock you over too much. Right? Now, again, you're young, you can have you don't need to worry about it for the most part. When you get to be an old fart like me, what happens is as we get older, our body tends to make more cholesterol, which means that I don't have to, even if I don't eat any cholesterol, which I can't, I'm a Southerner, there's no way. What that means is, even if I don't eat cholesterol, I'm still going to have an elevated cholesterol level because my body's making it. So what I have to do is to have various pharmacologic drugs to suppress it. For instance, I'm on statins. That reduces my cholesterol levels. All right? So the point here is this. Cholesterol is thought to play the initiating role. But generally speaking, it's not so much. So it doesn't matter so much what you eat unless your body genetically is producing a crap load of cholesterol. That is really important, okay? All right. What you're looking at here, I've been talking about this. I should move this forward, but we were talking about the coronary system. So remember, these are all the blood vessels in the heart, all right? So this is what we're seeing here. And over here is where we have an occluded X here, and then in this particular case, this is basically what I was just showing you here, how the atherosclerotic plaque forms and it occludes the vessel, right? Now, what this means is, where is the occlusion? Where does the occlusion occur? If the occlusion occurs here, that means that everything downstream is deprived of oxygen, right? So if you have an occlusion here, that's going to affect everything here. What's all this down here? That's the ventricles. So if I compromise the function of the ventricles, what does this mean? I'm not going to be able to pump blood through the body. All right. What if it happens here? I may not have any clinical impact because it's such a minor part of the ventricles. It doesn't impact their overall functionality. All right. So what it boils down to this, it all depends on luck. It all depends on, because these are random, they don't necessarily, they can occur anywhere in the coronary circulation system. So depending on where they are, where you have these occlusions, assuming you don't correct them, where these occlusions occur will determine your outcome from a heart attack. Okay? Which we will cover in just a moment. But before we get there, I want to talk about the third way. So we've talked about vascular spasms, which are usually not health threatening. Second, we talked about atherosclerosis. Next, let's talk about thromboembolisms. Okay. So basically, what is a thromboembolism? Thromboembolism is where you have a blood clot that's moving inside the circulatory system. That blood clot has volume. Okay? Think about a little plug flowing through the system. It will move until the vessel's too small in diameter for it to pass. It jams up, and that means that blocks everything from downstream. Okay? What is the thromboembolism. All right? Now, this may reflect here. When, for instance, maybe this atherosclerotic plaque is growing, it breaks off, now it's in the circulation, it flows until the holes are too big for it to pass. It can also be a result of surgical traumatic injury, right? Your guys are too young, but let's say you go for a hip replacement. That means my hip joint has degraded to the point I have to replace with an artificial joint. Okay, this is major surgery. All right. So you're going to have to cut up from here. You're going to expose. You're going to use a hammer, a chisel, drills. It's major trauma. Okay. So what they do for you is before surgery, they're going to thin your blood. What does that mean? They're going to put you on blood thinners, which means that they're going to give you drugs which will suppress your clotting, your blood clotting. So this is to reduce blood clot. But wait a minute, there is a fine line between you want to stop the blood from clotting, but you don't want to inhibit it completely because otherwise you'll bleed to death because you're just doing surgery, cutting all kinds of blood vessels. So they will give you these thinners, and we'll talk about those later, or they will also put compressive bandages on your lower legs, stockings on your lower legs, right? Why? Because the blood flows from here to your feet and then back up, all right? So they're going to be doing surgery here. There is always the possibility of some of these blood clots getting into the circulatory system. They go down here, they come back up. What's the downside? We have these little plugs flowing through the body. They will go to where they get stopped up. Depending on where they're stopped up, does that disrupt functionality of that particular organ or tissue? Okay, three places where we commonly see these blood vessels interrupting blood flow. The lungs, but usually that's not life-threatening. The other two are. The first one, if it goes to the brain, we have a stroke. Because if that's significant enough, that can result in minimal damage or death. Same thing in the heart. If it goes into the coronary system, depending on the level of blockage, you can have death result. All right. Now, because it's random to a certain extent, it all depends on where that plug is. That means that you can, if it substantially is driving function contraction of the ventricles and they're not working, you're not pumping blood, that means you have death, immediate death. Okay. Then you can have various degrees back from that. You can have delayed death. So we've had significant damage to the ventricles, but they're still functioning, at least for now. But now they have to overwork what is remaining, and then maybe you succumb weeks or months later. You can also have a full functional recovery. So there is a clinical impact, but the damage is such that the heart can overcome that damage. Or you may have some repair, you may have some functionality recover, but it's not full functionality. You have some limitations. All of these are possible because it all depends on where in that coronary system gets blocked, right? Okay. And you know something? I'm going to stop here. All right. We have seminar in a few minutes. And since I was on this person coming from Pitt, I've known them since they were a PhD student. I was on their committee and we currently do research together. I cannot miss it. So I'll leave us go early and we will continue this discussion on Tuesday. Right? Your homework for this week has been posted. It should be available in about 16 minutes. Right?